Mhm.
Good evening. We'll wait for 2 more minutes till we start. We're just waiting for the other participants.
Ladies and gentlemen, a very good evening to all of you. I am Fazan Yusuf, the National Activities Coordinator for SNO India, and I welcome you all to this live webinar on clinical and diagnostic approach in cases of hepatitis, proudly organized by SNO India. Today, on this World Hepatitis Day, we come together to delve into the intricacies of hepatitis, a global health challenge affecting millions worldwide. SNO India is an autonomous body within the network towards unity for health and is in official relationship with the World Health Organization. The mission of SNO India is to empower and support medical students, professionals, and the healthcare sector in India. Now, before we begin with the session, I would like to inform all the participants that we will be providing feedback forms, and at the end of the session, you are all requested to fill them. Ladies and gentlemen, I now take the honor to introduce to you the current National President of SNO India, Dr. Lakhan Prakash Gupta, sir. Dr. Lakhan Prakash Gupta, National President of SNO India, did his MBBS from JNMCH, Aligarh Muslim University, Aligarh. Dr. Lakhan is a passionate advocate of fervent leadership and adept healthcare management skills. His unwavering aspiration is to introduce pioneering ideas into the global healthcare arena, addressing the myriad challenges faced by the general populace. With esteemed roles as the president of JN Medical College Society, AMU, and the national president of SNO India, Sir has demonstrated exceptional leadership capabilities. Notably, Sir has also served as the National Joint Secretary for Indian Medical Association MSN HQs and as co-chairperson for WMA Cooperating Center UNESCO, Chair Haifa for Bioaesthetics SNO India, and the state president of IMA MSN UP. Sir successfully attained approval for his research project under STS ICMR. Driven by a profound sense of social responsibility, Dr. Gupta is committed to uplifting the standards of medical education and effectuating a lasting and transformative impact in the realm of healthcare and medical education. Ladies and gentlemen, Dr. Lukunsa for you. Over to you, sir.
Hello. Then I'm audible.
Yes, sir.
Good evening, everyone, and good evening, ma'am.
Good evening.
So, reading from SNO Indian National, I yes, please. Reading from SNO Indian National. I state here the lead of SNO India, humbled and honored on this significant occasion of World Hepatitis Day. Today's online workshop on clinical and diagnostic approach in case of hepatitis is a crucial step in our collective effort to combat this pressing global health challenge. First of all, I would like to welcome our respected guest speaker, Dr. Ragini. Thank you, ma'am, for taking out your valuable time and joining us today here. Hepatitis affects millions of worldwide, and it is imperative that we address this issue with utmost dedication and expertise. This workshop brings together our esteemed faculty, Dr. Ragini ma'am, to enhance our understanding and approach toward diagnosing and management hepatitis. Furthermore, let us not forget the power of awareness and education in prevention as we equip ourselves with the advanced clinical and diagnostic roles. Let us also dedicate effort to educate the public about the risk factor, preventive measures, and available resources for hepatitis. On this World Hepatitis Day, let us unite in our commitment to creating a healthier future for all. Overcome the challenges that hepatitis present and build a world where no one suffers from preventable and treatment. I extend my heartfelt gratitude to all my participants, organizing team, and our esteemed guest speaker, ma'am, for their dedication and support in making this workshop a reality. May our collective effort drive us closer to a world free from. Thank you, and let us move forward with the renewed determination. And thank you.
Thank you, sir, for your words of wisdom. I would now like to invite Anushka Das, the National Activities Coordinator for SNO India, to introduce our guest speaker for the day. Over to you, Anushka.
Thank you, Fazan. In this seminar, we aim to raise awareness about the impact of hepatitis, its modes of transmission, and the importance of early detection and timely treatment. Our speaker for today is Dr. Ragini Kilambi, a well-renowned associate professor in the Department of Hepatopancreatobiliary Surgery from IIBS Delhi. Dr. Ragini did her MS General Surgery and then MCH in Gastrointestinal Surgery and Liver Transplantation from the All India Institute of Medical Sciences, New Delhi. She also worked at the Gastrointestinal and HPV Surgery Department, SGPGI, Lucknow. After completing her MCH, she continued to pursue her keen interest in research and academics by working as a senior research associate in the Department of Gastrointestinal Surgery at AIIMS. During her residency, she had been trained in the fields of laparoscopic and open hepatobiliary pancreatic and numeral surgery. She has an active interest in research and academics and has a number of publications in various national and international journals and textbooks to her credit. She has also presented papers and posters in various national and international conferences and won awards for the same. Her areas of interest include advanced laparoscopy, hepatobiliary, pancreatic cancers, and acute and chronic pancreatitis. Welcome, ma'am, and over to you.
Thank you all. So, first, I'd like to take this opportunity to thank Lakhan, whom I know personally, and the entire organizing team at the Students Network Organization for giving me this opportunity. It is a pleasure to be talking to young generation and to students. And today, we are here on the occasion of World Hepatitis Day to talk about the clinical and diagnostic approaches to hepatitis. Can you allow me to share my screen so that I can share the presentation? Um, am I audible?
Yes, ma'am.
Can you please allow me to share my screen so that I can share my presentation?
Ma'am, you can share now.
Yeah. Okay. Thank you. Mhm. Mhm. Is my screen visible right now?
Yes, ma'am.
The screen is visible. Okay. Um, okay. Yeah. Um, so, uh, the theme for this year's World Hepatitis Day is One Life, One Liver, which is basically to emphasize on the role of liver in life and how it is an organ which has got multitude of effects on multiple other organs, and the damage to this one organ could actually essentially lead on to death, similar to what we think about in terms of heart or the brain. So now today we gather here to talk about the clinical and diagnostic approaches. I think the topic was in cases of hepatitis, but I shifted to viral hepatitis because that is our focus here. So the term hepatitis, so any itis indicates inflammation, and hepatitis therefore is a broad term covering any inflammation of the liver. So it could be because of various causes like infectious, it could be viral, bacterial, fungal, parasitic, or it could be non-infectious causes like alcohol, drugs, or any autoimmune diseases, metabolic diseases, and so on and so forth. But we focus here only on the viral hepatitis. So viral hepatitis is primarily inflammation of the liver that is caused by the infiltration of hepatocytes viral infected particles in portal and periportal areas. So this is just a very complicated way of saying that these are viruses that attack your liver cells and they're going to cause damage to your liver cells, the hepatocytes. So some of the viruses like hepatitis A or C virus or E virus are by themselves cytotoxic, and others like hepatitis B virus, even though it has its own potential to cause damage to the liver, most of the damage that occurs is because of your actual immune system, which attacks cells, the hepatocytes which are infected with the viruses. So now viral hepatitis is broadly divided into one which is caused by hepatotropic viruses, which are our common A, B, C, D, E viruses, and the non-hepatotropic viruses, which basically affect the liver as a part of the systemic insult. So these include your cytomegalovirus, Epstein-Barr virus, herpes simplex virus, dengue, influenza, Coxsackie, eco, varicella zoster, and so on and so forth. The list is endless. So why is everybody concerned about viral hepatitis? So the WHO has dedicated an entire day celebration of the hepatitis. Our goal is to eliminate hepatitis C by the year 2030. But C is burden of disease. It is big. Data is very sparse, so the exact burden is not established. Which suffices to say that WHO in its global estimate in 2016 found that nearly 40 million people are infected chronically with hepatitis. E virus is the most common cause of epidemic hepatitis and accounts for a substantial number of acute liver failures. Hepatitis A virus, on the other hand, is an important cause of hepatitis in children. Again, to put some perspective into the numbers, nearly 78,000 people are infected with acute hepatitis. Another 20,000 have liver cancer, secondary to hepatitis B or C, and a close to 1,73,000 people have got cirrhosis because of hepatitis B and C. Nearly 2.85% hepatitis in its various. Putting all these numbers into perspective, close to a third of acute hepatitis is contributed to hepatitis A and E virus. Of the A virus, nearly 5 to 15% will develop ALF, acute liver failure, and a fifth to nearly a half of hepatitis E virus will develop acute liver failure. The surface antigen is used for finding the endemicity. So the B surface antigen prevalence rates are around 4%, which puts India into the intermediate endemicity zone. Similarly, the antibody prevalence is close to 1 to 15%, which nearly indicates 6 to 12 million people as seen. Chronic infection accounts for nearly half the cases of hepatitis, of hepatocellular carcinoma, a third of cases of cirrhosis, and Hep C accounts for nearly 30% of cases of HCC and a fifth of cases of cirrhosis. So it is of interest for us to control hepatitis. not only because it contributes significantly to mortality, it's a communicable disease, it's a preventable disease, and it's a mortality that can be prevented. It also accounts significant morbidity when it turns into a chronic infection, places a great strain on healthcare resources, and also results in a amount of work days lost, as well as loss of manpower. So viral hepatitis predominantly presents two patterns. So one is your acute hepatitis, and the other is the chronic hepatitis. So all viruses, whether it is A, B, C, D, or E, capable of causing viral hepatitis. So here you have a rapid onset of infection, and usually asymptomatic. Oftentimes, it is detected on routine blood testing or screening programs, or when people go for donating blood or routine health checkups. So, it was earlier believed that only the hepatitis virus B, C, and D is capable of causing chronic viral hepatitis. Today, what we do know is that hepatitis A virus, even though by itself will not become chronic, it can trigger autoimmune hepatitis in a subset of patients who are genetically susceptible. Similarly, a lot of literature has been now published that hepatitis E virus can cause chronic liver disease in patients who are immunosuppressed, especially post-transplant patients, post-kidney transplant patients, and those who have so normally viral hepatitis can present with acute hepatitis, acute liver failure, acute and chronic liver failure. So first we look at what is acute viral hepatitis. So this is what is we seen. It's seen with all the viruses A, B, C, D, and E, and it presents is the disease is categorized into four phases. So you have the first phase, which is the preclinical or the incubation phase, and phase two, which is the pre-ictic or the prodromal phase, the third phase, which is the ictic phase, and the fourth phase, which is of convalescence or recovery. So, in the first phase, which is a preclinical or the incubation phase, as the name suggests, this is from the time of infection till the time of onset of symptoms. So, patient is essentially asymptomatic, however, viral replication occurs. And there may be some amount of serological or enzymatic abnormalities which can be noticed in this patients are housed during the period. This is pre-trick or the prodromal phase, which is characterized by the typical viral prodrome, which is associated with hepatitis. It's associated with malaise, low grade fever, diarrhea, nausea, vomiting, and now this phase lasts for several days up to more than a week. This then gives way to ictic phase, where, as the name indicates, patients become jaundiced. So, depending upon the type of virus we are talking about, this could be usually low grade jaundice of 2 to 5 milligrams, but even up to 20 to 40 milligrams, uh, this 2 to 4 milligrams per deciliter is what is usually seen in this. But even higher levels can be seen, especially when patients go into acute liver failure. So then in the ictic phase, typically patient develops high colored urine, clay colored stools, yellowish discoloration of conjunctiva and sclera. It begins usually within 10 days of the initial onset of symptoms. By the time the patient enters into the ectric phase, the fever abate, the viremia also terminates. However, the feces do remain infectious for another 1 to 2 weeks, and therefore the patient will remain infectious. This finally gives way to the convalescent phase, where the symptoms and the icterus resolve and liver enzymes gradually return back to normal. So, this is acute viral infection. Now, the natural history of this could be a spontaneous resolution. So, after the convalescence, there will be clearance of all the antigen particles and antibodies will develop, which then confer immunity, which is spontaneous resolution. Or this could pave way to an acute liver failure like picture, or a fulminant liver failure, or it can go on to become a chronic infection without resolving. So, acute liver failure, what do we mean by this? Acute hepatitis can progress with the deterioration of liver function, manifested mainly in the form of coagulopathy with an INR which is more than 1.5, and alteration in the mental status, it is encephalopathy in a previously healthy individual. Now, depending upon how rapidly this sets in, so if this encephalopathy develops within 8 weeks of onset of symptoms, it's called as a fulminant hepatic failure. When it takes between 6 to 8 weeks of onset of symptoms, it's called as a chronic hepatic failure. Patient would require fulminant hepatic transplant and would die in the absence of transplant, even though about half would resolve. But What is more difficult is to find out those individuals who are likely to improve versus those who are not going to improve without treatment. So the symptoms of acute liver failure would be encephalopathy. Now, it is important to note here that this encephalopathy, unlike in cirrhosis, is not because the ammonia levels are going up, but rather it is because of cerebral edema, because of the osmotic changes that are taking place. Again, an important factor is the cerebral edema because once the cerebral edema increases and papillary edema sets in with hypertension and bradycardia, at that point of time, neurological recovery is unlikely to happen even if you do a transplant at this stage. Jaundice most often present. Ascites and hematemesis in melena often occur when this acute failure is superimposed on a chronic background, not by itself, usually in the acute phase. Hypotension, tachycardia all occur because of reduced systemic vascular resistance. So the next presentation would be that of a chronic viral hepatitis. So the acute can give way to a chronic viral hepatitis. So what happens is that whenever these antigens persist for more than 6 weeks, it's termed as a chronic hepatitis. Hello. Hello. Am I audible? Am I audible?
Yes, ma'am. Maria, can you please check the mic?
Chronic spread interestingly depend upon the age at the time of infection. So when there's a vertical transmission or there's an early perinatal transmission that occurs, then 90% of these neonates go on to develop a chronic infection. This is stark contrast to adults where only 1 to 5% of patients will actually develop a chronic infection after an acute infection. It's hepatitis. Now, this is the opposite is with the hepatitis C viral infection. So, almost 75 to 85% of patients who develop acute viral hepatitis C will go on to develop a chronic infection. And interestingly, those who develop hepatitis C at a younger age are less likely to develop the chronic infection. Older people develop it more. Now, the chronic hepatitis phase is characterized by either it could be asymptomatic, but more often presents with some amount of fatigue, some amount of unwellness, and progresses gradually to cirrhosis. So, if we look at the chances of developing chronic viral hepatitis, whenever there is a hepatitis D virus super infection on hepatitis B virus, there is a 100% chance of developing chronicity. The next highest chance is with perinatal transmission of hepatitis B virus, which is nearly 90%. And then is 85%. Hepatitis B and hepatitis E virus so now we call it as a chronic infection hepatitis B virus when the hepatitis B surface antigen, the E antigen, and the DNA persist in the serum for longer than 6 months. With hepatitis C, if the RNA persists for longer than 6 months, it's called as a chronic infection. A is not being reported to progress to chronic hepatitis, and while E is now being increasingly reported to liver transplant and otherwise immunocompromised. These viruses. So we've got the hepatitis A virus. So we have got mainly 5 viruses, E. There's also a G virus, which is not considered to be the pathology, so it's not usually discussed in this context. So apart from the hepatitis B virus, which is a DNA of spread of these viruses. So A and E essentially have a fecal-oral spread, which basically is why they are endemic to our country because of the poor hygiene conditions. So with improvement of hygiene conditions, you could expect a reduction in these in the transmission of these viruses. B, C, and D are those which are parenterally transmitted, usually through blood and blood products. B also shows vertical transmission, C and D not as much. And sexual transmission is also reported with B virus and C virus. Hepatitis A, B, C, and C viruses are also found in saliva and have been known to be transmitted through saliva as well. So now we try to look at each of these viruses briefly. So hepatitis A virus, it has an incubation phase. Average is around 4 weeks. So during the infective phase, the virus is excreted in the stool, and this is usually in the first few weeks after infection, before the onset of symptoms. That is, most of it is in the incubation phase. Young children are usually asymptomatic when infected with hepatitis A. It is actually the adults who have a very severe form of disease and a higher mortality. This is similar to what you see in chicks, followed by complete recovery with no cases of chronic hepatitis reported. So typically in the prodromal phase, they'll have malaise, anorexia, nausea, vomiting, of liver enzymes. Jaundice, very low grade is seen. It is more seen when you have a severe case alone. Now, it is interesting that people can keep experiencing relapses up to an year in hepatitis A virus, even though they do not go on for chronicity. Fulminant failures are not very common, they're less than 1%. Now, this is a graph that depicts to what happens in the hepatitis A virus infection. So, once you receive the infection, immediately viremia starts, and this A virus starts getting excreted into your feces. So, the child becomes infectious. Over a couple of 2 to 3 weeks, there is onset of clinical illness. At the same time, by 4 weeks, the enzyme levels, that is ALT, starts to increase and peaks by about 4 weeks and then starts to come down as the body starts to recover. The anti-hepatitis A antibody, that is IgM levels, start to increase by 2 weeks and peak by around 4 weeks. And concomitant with the decline in the IgM levels would be a decline in your enzymes, liver enzyme levels, as well as resolution of your viremia. Following this, the IgG levels start to increase by about 4 weeks. So, if you do a blood test and you find anti-HAV IgM antibodies, it indicates that the patient has got acute hepatitis. And there is a rapid increase in the titers over 4 to 6 weeks, but it returns back to undetectable levels within 3 months. When you look at the total antibodies, that are IgG plus IgM, they are going to remain positive, and their presence indicates that either there has been a vaccination which has resulted in immunity, or there has been a previous infection which has resulted in immunity, and they will appear shortly after the symptoms, and they confer lifelong immunity, which is why vaccination is available for hepatitis A virus. Next, we come to what is the most interesting virus and most elusive virus of all, hepatitis B virus. This is the subject of most of the research which is happening is in this. So, incubation period, easy to remember, 6 weeks to 6 months. Average of around 5 adults, 50% of children who are infected between the ages of 1 to 5 go on to develop chronic infection. The remaining will develop anti-HBs surface antigen antibodies, and they clear off their surface antigen and fully recover. So there has got 4 phases. You have an immune tolerant phase, you have an immune active phase, you have an immune control phase, and you have a reactivation phase. Not all phases are seen in all individuals. So I'll show you this in the next graph, which will make it easier for you to understand what happens. So the first is the immune tolerant phase. This predominantly seen in young individuals. That is basically perinatal transmission, either vertical transmission or when transmission occurs in the first few years of life. So at this point in time, the immunity levels are not very high. So we go back and recollect that a lot of damage that happens in hepatitis B hepatitis is primarily because of the immune system. So this, even though the virus is also cytotoxic, it is actually the immune mediated toxicity by the cytotoxic T cells which cause more damage to the liver and are responsible for your elevated liver enzymes as well as the ongoing chronic hepatitis and regeneration and cirrhosis. So, in the immune tolerant phase, in these young babies who do not have much of an immune system, even though the HBE antigen, which is a reflection of the replication, and the HBV DNA, which is again a marker of the replication of the virus, is happening. So, both are on the higher side. The surface antigens are positive. The ALT levels, the liver enzyme, the alanine transaminases would be normal. And on a biopsy, if you were to do biopsy, you would see minimal inflammation because immune system has not mounted any response. So the virus is happily sitting and multiplying. Now, eventually, these individuals will step into the immune active phase. So here, the immune system will gradually start taking over and attacking the viruses and the cells which are infected with the viruses. So once the immune system becomes levels increase. This decline in the HBE as well as levels. So with time, that treatments are offered to most patients. Then is the phase of immune control phase. So here, by this time, the HBE antigen becomes negative. anti-HBE antibodies will develop, the DNA levels start to decline to less than 2000, and the enzyme levels will start returning back to normal. And also, again, on biopsy, you would only see minimal amount of activity. Now, if already a lot of damage has occurred in the immune active phase, these could then otherwise, at that point in time, you would not have much of damage to the liver happening. Now, the individuals can continue in this phase for a long period of time. However, at times there could be a mutation in the core antibody antigen of this virus, which results in the virus starting to replicate again. So the Hep B DNA will go up, even though E antigen will remain negative. There will have anti-hepatitis B E positivity will be there, but this is called as immune escape. So DNA starts to multiply. Typically, they would have liver insult, they will have increase in the ALT levels, but the multiplication and the DNA numbers would not be as high as when they are in the normal phase. So this is about the hepatitis B. So you have the immune phase where due to the tolerance you have a normal liver histology. In the active phase there is active inflammation with increased ALT levels, and this phase ends with development of anti-HBE antibodies, and you enter into the immune control phase. Now, after the acute viral insult, the acute viral hepatitis, some individuals can enter into an inactive carrier state as well. And what is this inactive carrier state? So they seroconvert, E antigen will become E negative. The blood test will be same, there will be no inflammation, and there will be replication will also be minimal. They continue to be surface antigen positive. So they continue to be infectious. So the virus is still there, even antigens will be positive. Some of these can very they will become surface antigen negative and also develop antigen. They could enter into the chronic hepatitis stage and enter into the immune active or immune control phase, and then go on to enter into the reactivation or immune escape phase as well. So for the inactive carrier state, when there's not much of multiplication happening and the blood tests are normal, again you don't have any antiviral therapy at this stage. So this is a graph hepatitis B virus and to the antigen levels. So, immediately after an infection, within around 4 weeks, the HBS antigen, surface antigen, appears in the bloodstream. This is at this time that you will also have the appearance of the hepatitis B DNA. So, the DNA also starts to multiply, and so also the hepatitis B E antigen. By about 8 weeks, they start to develop the clinical symptoms, manifestations of prodrome, etc. At this time, the ALT levels will, at this time, you will see that there's an increase in the IgM levels, the anti-hepatitis B core antibody. So it is important to remember that you will not usually be able to identify the core antigen. It is inside the virus. So the antigen is never detected, but the core antibody is. So IgM core antibody becomes detectable. So as we have seen, it is the immune system which causes damage. So this core antibody is accompanied by an increase in the ALT levels as well. So here you have this purple line which depicts the IgM levels and this dark green line which depicts ALT levels. So over a period of 6 months, the HbA surface antigen starts to clear. The IgM levels then decline within another 2 months, that is by 8 months. By this time, it starts getting replaced by the IgG antibody so that the total anti-HB core antibodies increase. By it, another 4 months, that is by around 10 to 12 months, the DNA levels become undetectable. By 8 months, the anti-hepatitis B surface antigen antibody appears in the bloodstream. At the same time, this E antigen, when the IgM E antigen disappears and the E antibody appears. So this is when you have complete recovery. So at the end of the day, you will have anti-hepatitis B E antibodies, you will have anti-hepatitis B core antibodies, and you'll have anti-hepatitis B surface antibodies. The antigens and DNA and hepatitis B E antigen, these three are undetectable. So what happens when you have chronic hepatitis B? So the initial part remains the same, whether it is acute or chronic hepatitis. So by 4 weeks, you have an increase in hepatitis B, E antigen levels, the surface antigen levels, and the DNA levels. ALT also starts to rise simultaneously. But however, what happens here is the IgM levels will fall, but this will not be accompanied by disappearance of your surface antigen or of E antigen. E antigen persists. There is no E antibody being formed, and there is no and level persists. So this is what happens, and so if we look at the interpretation, so if you do a blood test, so you look for hepatitis B surface antigen. So that is the first test for diagnosing hepatitis B viral infection. So if your surface antigen is positive, the next thing you need to know is it an acute infection or is it a chronic infection? So you look at the core antibody. So these core antibody, if IgM is present, this will be accompanied by E antigen positivity as well. And this indicates that currently the patient is having an acute episode of hepatitis B and the patient is highly infectious. Suppose IgG is positive and hepatitis B E antigen is positive, it indicates that the patient continues to remain infectious since E antigen is positive. The next scenario is when your hepatitis B surface antigens are negative. However, if your anti-hepatitis B surface antibody is positive, your IgG core antibody is positive, with or without anti-hepatitis B body, it indicates that the patient has
Please stay tuned. Ma'am will be back shortly. The technical team is looking into it. Stay tuned, guys. Ma'am will join shortly.
Respected delegates, apologies for the delay. Ma'am will be joining for soon.
In the meantime, if any of the participants have any questions, you're like free to put them in the chat box.
While the technical team sorts this out, I request everyone to turn on their camera so that we can click some pictures for our social media handles.
Hello.
Good evening, everyone. Sincere apologies from SNO India due to some technical issues. We are not able to continue the workshop, but thank you everyone for joining. I would just like to end with it that hepatitis B virus specifically infects hepatocytes and causes severe liver diseases. The HBV life cycle is unique in that the genomic DNA is converted to a molecular template DNA to amplify a viral RNA intermediate, which is then reverse transcribed back to viral DNA. The highly stable characteristics of CCC DNA result in chronic infection and a poor rate of cure. This complex life cycle of HBV offers a variety of targets to develop antiviral agents. As we all know that HBV virus is a very common infection that can take place in our daily to daily practices. So we need to be sure and we need to be clear with how we manage in our how we manage in our day-to-day clinics and we should stay aware and we should be very careful dealing with the cases. We will be now be providing with the feedback form.
Link for the feedback form has been shared in the chat box.
The feedback form will be open for only 10 minutes, so kindly make sure that you fill it, otherwise you will be getting the certificate.
Good evening, ma'am. Ragini, ma'am.
Hello.
Yes,
Good evening. I'm sorry. I think I got this. Yeah, I'm sorry. I think
yes, ma'am. It's okay, ma'am.
time and till time.
Ma'am, you still aren't audible very properly.
You're. Am I audible now?
Yes, ma'am. Yes, ma'am.
Am I audible now?
Yes, ma'am.
So I'm just sorry. I got disconnected, and since my screen was sharing my slides, I did not realize that I got disconnected. So could you just guide me at what point in time I got disconnected?
Ma'am, at the HPV life cycle at slide number 27.
Okay, okay. So you want me to go through this again?
Ma'am, actually, we haven't been
So
able
this
to.
was the slide on which.
Yes, ma'am, the slides
Yeah.
are visible to us.
Yeah. Okay. Obviously, I mean, and probably I was not audible as well, is it?
Yes, ma'am.
Okay. So I'll do one thing. I'll bear with me till this slide. Okay. I'll just show you my slides now.
Yes, ma'am.
This is the slides now. It is the slides now. It is the slides now. Am I audible?
Yes, ma'am. This was the
Yes,
slide,
ma'am.
ma'am.
Yeah, this was a slide. We were here.
Yes, ma'am.
Because
Yes,
I've
ma'am.
overstepped my because I didn't realize my this. Want me to go? Okay. So I'll try to shorten it this time around. So
Yes, ma'am, we were done with this table.
So, okay. So, chronic infection happens in around 10 to 30% of the carriers. Most of them will be symptomatic with fatigue, and they'll occasionally have disease flares as well. And they'll have extrahepatic manifestations as well. So, hepatocellular carcinoma, again, another complication of hepatitis B virus. Now, hepatitis B will go on to develop cirrhosis, and 2 to 5% of these will develop hepatocellular cancer. So, what happens is that when there is liver injury, there is obviously an attempt at repair and regeneration. So, there will be regenerative nodules which will be formed, comprising of the regenerative areas along with fibrosis and scarring in the repair areas. So, whenever there is extensive inflammation, so that is a background for a malignancy to develop, for errors to happen in the replication. So that is how HCC develops in a background for However, what is important to understand here is that hepatitis B virus is a DNA virus. So it can get integrated into the genome and result in activation of oncogenes and suppression of tumor suppressor genes and result in a malignancy even without progressing to the stage of cirrhosis. So next, coming over to treatment. Again, this is also very interesting because not all patients with hepatitis B need to be treated. This is because the currently available treatment modalities can only suppress viral replication. They cannot produce a cure. And all treatments are essentially lifelong. So, simple, easy way of remembering is treat all patients who have reached the stage of cirrhosis, irrespective of their DNA and hepatitis B E antigen levels or the enzyme levels. For the rest, look at the DNA levels and the enzyme levels. So, if you have E antigen positivity and your DNA levels are upwards of 20,000 and your enzyme levels are persistent, it has to be higher for more than 3 months. So, these are candidates for treatment. When you are these patients should be monitored 3 monthly with liver function tests. Biopsy needs to be individualized. So you need to do a biopsy in patients who have a very strict HCC or cirrhosis, or patients who are more than 30 years of age, or who have evidence of significant fibrosis on fibroscan, meaning a fibroscan levels of more than 8. Anytime in the biopsy, if you are seeing moderate to severe inflammation or significant fibrosis, they become candidates for treatment for Hep B, irrespective of their DNA levels. Uh, I'm still there. You're still there with me?
Yes, ma'am. You're now audible.
Yeah. Yeah. So these are the patients who are hepatitis B E antigen negative, but so their DNA levels will not be very high. So their DNA levels will be usually less than 2,000. When they won't go to 20,000 range. So when their DNA levels are more than 2,000 and their ALT levels are high of more than 2 times the upper limit, they should be treated if it's persistent and they do not seroconvert. For the remaining, it is the same thing that you need to look at the amount of fibrosis, you need to look at other sources of elevated ALT, you need to monitor them, you need to individualize the need for biopsy. If you get moderate to severe inflammation, then you need to treat them. Otherwise, you can just wait. Now, whom should you go and treat? So, like I said, all patients who have cirrhosis, decompensated, non-decompensated, should be treated. People in persistently high ALT levels and high DNA levels, more than 20,000, to be treated. All others should be continuously monitored and every 3 months for checking when they become eligible for treatment. Hepatitis D virus. So this D virus is something that affects only patients who are affected with B virus. So it cannot infect people who do not have B virus. By itself, it cannot infect any individual. It has an incubation period ranging from 30 to 180 days. So it can be either a co-infection when B and D virus infection occurs simultaneously, or it could be a super infection antibody and IgM levels. So this is a picture which depicts the same. So you have a co-infection. When co-infection happens, they behave almost the same way as that of your hepatitis B virus infection. So there will be 3% chance of fulminant failure, 90% will recover, and 5% will develop chronic infection. Whereas super infection has a much worse outcome. So 7 to 10% will develop fulminant hepatitis, 10 to 15% will have very acute severe disease flare, and 80% will go on to develop chronic hepatitis. However, even those who have a co-infection will have a more rapid progression to cirrhosis as compared to those who have only hepatitis B virus infection. Uh, if we look at the incubation period for the hepatitis C virus now, it is around 15 to 160 days. Most of these patients have mild disease. The acute phase is very mild in these patients. Then around 15 to 45% will recover, but the vast majority, that is about 55 to 85%, will develop chronic disease. This is again a pictorial representation of the same. So if you have symptomatic hepatitis, you still have a 40% chance of clearance. If you have asymptomatic infection, only 15% chance of clearance. The rest develop chronic infection, which progresses through phases of active hepatitis and cirrhosis over 20 years. And then these then go on to develop decompensation as well as hepatocellular carcinoma. So this is a picture which shows us what happens to the antigen viral levels as well as the antibody levels. So immediately after infection, the RNA levels start rising, they multiply. Along with that, there's an increase in the anti-HCV antibody levels. So by about 10 to 12 weeks, the antibody levels increase, the ALT levels start to come down, and the viremia disappears. Whereas when we have a similar picture, what happens in the chronic infection is even though the antibody levels, which is indicated by this green line, go up, the virus is not cleared. So the RNA replication continues, the RNA remains detectable, and the ALT levels keep going up and down depending upon the amount of inflammation that is happening in the liver. So if you look at the anti-HCV antibodies, how do we test? Testing is with only anti-HCV antibodies. So if you have anti-HCV positivity, then you have to look at the RNA levels. So if both are positive, it indicates the patient has got hepatitis C infection, be it acute or chronic. If you have anti-HCV but the RNA is negative, it indicates that the patient had infection but recovered and it is cleared. Or it could also be a false positive. If you do not have any anti-HCV but you have an HCV RNA, it indicates that you are early in the course of an infection and that antibodies have not developed as yet. Whereas if both are negative, it indicates an absence of infection. So how do we test? We look for the antibody first. And even though there is a small possibility of somebody being negative for antibody but positive for RNA, you do not test for RNA unless the antibody is positive. If you have a very high index of suspicion, you can retest the patient for an antibody after a couple of weeks and then look for RNA. So once the RNA is positive, they have to be treated as a current HCV infection. Next, coming over to the last virus, which is hepatitis E virus. Now, this has an incubation period of 2 to 10 weeks, usually produces a mild infection. However, it has a high mortality reaching up to 25%. It is also an important cause of ALF, and nearly half the patients with ALF will require transplant. So again, here is a graph that shows to what happens to the IgG and IgM antibodies. So immediately after an infection, this green line reflects your IgM antibody, which starts to rise. At the same time, the liver injury reflected by ALT levels starts to increase. You have an HEV RNA detectable in the stool and the serum at this time. By about 6 weeks, the ALT and the IgM levels have peaked. They start to come down. The IgG levels have started to go up. And by 12 weeks, your RNA levels become undetectable. IgG levels increase, IgM levels and ALT levels start returning back to normal. And by 3 months, the IgM levels are undetectable. So if you have IgM antibody, it indicates it's an acute infection. And if you have an IgG antibody, it indicates that there has been a past infection. However, these are not very protective, unlike what you see in HAV infections. Now, this is a graph which summarizes the same thing. So important thing here is, apart from what we have already seen, easy way to remember hepatitis A and E cause more often acute hepatitis, so they have short lasting incubation periods. B, C, and D have long incubation periods. B and C and D produce liver cirrhosis and therefore liver cancer as well. Now, as far as immunization is concerned, we have passive immunization for A and B. Even active immunization is available only for A and B. It's not available for C, D, and E. However, the vaccine against B, by protecting against B, also protects against D because D cannot exist independently. Trials are underway for hepatitis E virus, but no commercial vaccine is as yet available. So next we move over to what happens. How do you go about diagnosing? So where are the various clinical scenarios where you need to be testing patients for hepatitis? So the most common scenario are your blood donors, organ spectrum A, B, C, and E. Healthcare workers who have a needle stick injury have to be tested for B and C, as also pregnant females. Newborns who are born to hepatitis B surface antigen positive mothers need to be tested for hepatitis B prior to surgery, even though it's not a part of a program, nor is it mandatory as of now. So, what are the tests that you offer in non-jaundice patients? These would be B and C because you're looking by testing the surface antigen, then the patient has Hep B or Hep C, respectively. If these are negative, then the patient doesn't have these infections. Jaundice patients have to be tested for A, E, B, and C. So, in a jaundice patient, obviously, if IgM, HAV, or HEV is positive, then they have the infection. Similarly, anti-HCV, they have an infection. But with hepatitis B, you test for both hepatitis B surface antigen as well as the core antibody. So, if the surface antigen is positive along with the core antibody, then it indicates patient is infected. But if you're both, only if both are non-reactive would you consider that the patient is uninfected. Even if a core antibody is positive in the absence of hepatitis B surface antigen positivity, it could be the recovering infection, so it could still indicate that the patient is positive, and this could still account for your deranged liver function test. What are the testing methods that are there at our disposal? So, in very much in brief, we have three types of tests that are available: rapid diagnostic tests, serological tests, and your molecular tests, which are nucleic acid tests. So, your rapid diagnostic tests are your CART tests. So, these are similar to your drop I, drop T tests or your urine pregnancy tests. So, these are CART tests. You just put the sample in the well like this, and in a short time, the test and the control will tell you whether the patient has an infection or not. It's a point of care test, readily available, no need of any extensive infrastructure, very low cost, very simple, anybody can do. However, the sensitivity is bound to be low. The serological tests that are available to us are two, mainly ELISA, which is enzyme linked immunosorbent assay, and you have the chemilucence test. So they both work on the principle of antigen antibody reaction. So the antigen is absorbed onto the well, and then the antibody is added, which will bind to the which will bind to the antigen, and then the substrate is added, which would bind to the antibody. If it is bound, if the antigen has been present and the antibody binds to it, it will bind to that, and this is how you can recognize the presence of antibodies to these things. Chemilucence is different from your ELISA only in that here the substrate is luminescent, so it is visually appreciable. Also, these are point of care tests. The results are available faster than ELISA, and even one sample can be processed at a time, in contrast to ELISA, which requires multiple samples to be processed. And this has a sensitivity which is at par with that of ELISA. Nucleic acid testing is required for identification of hepatitis B virus DNA or hepatitis C virus RNA. Genotyping using the next gen sequencing is used for investigation of epidemics, for assessing treatment response of specific genotypes, for finding which genotypes are more responsible for cirrhosis or for hepatocellular carcinoma, etc. To summarize, viral hepatitis, as we have seen, is a very important public health issue. It contributes significantly to morbidity as well as mortality. Uh, the primarily hepatitis A and E are spread through the fecal-oral route and are communicable. The B and C cirrhosis exists with B virus and C virus. Important thing for us to remember is that A and B have effective vaccines available and are completely preventable with universal immunization. Hepatitis B virus has been included in your universal immunization schedule as well. Hepatitis C has got effective treatment available and is completely treatable. The goal is to eliminate hepatitis C by 2030. Thank you. I think I've already overstepped my time because of my loss of connection. But if there are any questions, I'm happy to take them.
Thank you, Dr. Ragini, for sharing your expertise on the subject. Your insightful presentations have enriched our understanding of hepatitis and inspired us all to take action and contribute to the fight against this disease. As we mentioned before, we have put the link of the feedback form in the chat box. The participants are requested to please fill in so that we can make the next experience better. Now, I would like to hand over to Faizan to conduct the question and answer session. Over to you, Faizan.
Thank you, Anushka. Thank you, Ragini ma'am. It was an absolute pleasure learning from you. We'll now be proceeding to the Q&A session. I request all the participants to feel free to ask your queries regarding the subject in the chat box. Meanwhile, ma'am, with your permission, can I ask you some of the questions we received during the registration?
Yeah, sure.
Thank you, ma'am. Ma'am, the first question is related to post-exposure prophylaxis for hepatitis B. The question is, what to do if someone accidentally has a needle stick injury for hepatitis B while treating a patient? And there are three scenarios to it. The first scenario is if the medical staff is not vaccinated, and if the medical staff is vaccinated.
So the first thing you need to do is you need to look at the anti-hepatitis B antibody levels. Okay, more than 10. Then you have adequate immunity, therefore unlikely to develop any issue. Then and I presume you're talking about a patient who you have been pricked by somebody who is already infected with hepatitis B, right? So otherwise, if you are not infected, if you have been just pricked by somebody and the status of the patient is not known, then the first thing to do is to test the patient and the healthcare worker both. So the healthcare worker needs to undergo a test for hepatitis B surface antigen and see whether already they have these things and whether the patient has it. The best case scenario is if the patient and the worker do not have, even then after 3 months you repeat the hepatitis B surface antigen for the healthcare worker. If the healthcare worker has got adequate levels of immunity with your antibody levels being more than 10, then most often this is protective and these people will not go on to develop any issues and you don't have to do anything further. If your titers are less or if you have not been vaccinated at all, in that case you have to wait and watch. You have to repeat your hepatitis B surface antigen and DNA levels at a later point in time. And if at that point in time your ALT levels go up, your DNA is present, that time you have to start on treatment. If the patient is known to be positive, then immunoglobulin can be administered. If you are being pricked by somebody who is known to be hepatitis B surface antigen positive and DNA is positive and the healthcare worker is not vaccinated, then those people can be given passive immunization with immunoglobulin to protect against developing an infection. But if the patient is also not positive and you are not vaccinated, then you just have to wait and watch. Medications are not as yet indicated. It is mainly the passive immunization. And then at the earliest, you should get your vaccination as well, also done. And I think currently it's a policy that in MBBS itself, as soon as you enter, you need to get yourself vaccinated in your first year of MBBS and at the time of your admission with hepatitis B and you have to produce a certificate. It is also not a bad idea to get yourself checked for your titers of the antibody after 5 years to see if any, because if your levels are less than 10, then that is an indication for you to get a booster for your hepatitis B vaccine. Because there are some people who do not seroconvert, they say, after vaccination. So even after your 3 doses, you will not mount an immune response adequate enough to protect, which is that 10, which is the level of 10 international units. So you may need to take a booster dose in such a case. I hope that answers your question.
Thank you, ma'am. Ma'am, what happens if in case of pregnancy? if a female gets infected with hepatitis B, what happens?
Mm. Right. So during the pregnancy, mm, at the time of delivery, post delivery, the child is covered with passive vaccination with your immunoglobulins, and you also have to vaccinate the child against hepatitis. That is the perinatal prevention of the vertical transmission. For the mother, post that she has to be started on tenofovir post the delivery, not during the pregnancy.
Thank you, ma'am. Ma'am, another question reads: what innovative strategies can be employed to in? Hello, am I? Hello.
Ragini mom.
Am I audible?
Yes, ma'am.
Am I audible?
Yes, ma'am.
Hello. Yeah, sorry, I think I got disconnected in. So where we were talking about hepatitis B in pregnancy, right? Baby has been protected after 3 to 6 months. And the other thing is about the antiviral treatment. So obviously in first trimester, it is absolutely contraindicated. But if your DNA levels continue to be very, very high, that is more than 20,000, then in third trimester, around the perinatal period, it can be started in a very carefully monitored way, but not in the first trimester. And that too, only select subgroup of patients who have high levels of your DNA, viral replication, who will be very high for high.
Thank you, ma'am. Ma'am, what innovative strategies can be employed to increase public awareness and engagement in the fight against hepatitis?
Whether it is innovative emphasis in just like you have using mediums of social media, the mass communication like television and all have been used for your tuberculosis or your polio virus vaccine campaign and all. So similarly, using these to advocate for testing and because as now there is for hepatitis A and hepatitis B virus, we have immunization which is adults not immunized against hepatitis connection चला जा रहा है. So everybody should have access to testing as well as treatment. So using media, social media. Today, everybody is on Facebook, everybody is on WhatsApp, everybody has got Instagram and everything. So using these to generate awareness about the existence of these diseases, hepatitis B, hepatitis C. The fact that hepatitis C is completely treatable. That is very important because you need to be tested, and only if you're tested, you can treat. And similarly, vaccination program should be strengthened. People should be informed about getting vaccinated against hepatitis B because it can prevent both B and D. As of C, we don't have a vaccine, but at least we've got very effective antivirals, directly acting antivirals, which have changed the entire scenario as far as HCV is concerned today. Even after cirrhosis has set in, these directly acting antivirals can prevent antivirals. So that way, then obviously patients who come to the hospitals, patients who get admitted for various treatments, for various procedures, they can be informed by means of pamphlets or by means of posters which are displayed inside hospitals, in your OPD areas, in your blood banks, where where you're expecting to see patient relatives being there. So by means of billboards on the roads, on the streets, you can inform people about the existence of these diseases, which are potentially treatable or at least preventable.
Thank you, ma'am. Ma'am, the next question is, in light of the ongoing COVID-19 pandemic, how has the landscape of hepatitis care and prevention changed, and what lessons can be learned for future pandemics?
I didn't get your question. In the light of, the voice is breaking. In the light of,
In the light of ongoing pandemic, in the light of the ongoing COVID-19 pandemic, how has the landscape of hepatitis care and prevention changed, and what lessons can be learned for future pandemics?
so you're talking about the COVID-19 pandemic and how the hepatitis B care has been affected by this. So to be very honest, COVID-19, at least in the initial phase in 2020 and first half of 2021, disrupted all programs, all health programs, all national immunization programs, whether it is your polio prevention drive or whatever. It affected everything. So also did it affect these hepatitis program. So we at ILBS run Project Prakash and empathy campaign where you sensitize the nursing staff. There is classes for the nursing staff when they're sensitized against hepatitis, and then you go to schools and then you teach the students. You conduct classes and small programs for school students because they become aware about what is hepatitis. Then you go into the community and offer pre-testing for patients. So obviously COVID-19 affected everything that had to do with the community because the total contact, because one, diversion of resources for the COVID-19 pandemic, and second, because of the pandemic, people restricted the human to human interaction. But yes, now we are back on the track. And as far as lessons which we have learned from the pandemic is concerned, I think one thing that needs to be understood is preparedness. So you need to invest in healthcare. You need to have extra in your hand if you want to be able to handle a situation like this pandemic or even any other epidemic happens, then you will not have enough manpower. So you always need to have some in excess to be able to fight when it comes to these emergency situations. And also, the pandemic taught us that you need to go back to your basics. You need to invest in hygiene. You need to invest in cleanliness. You need to invest in washing your hands, keeping yourself clean, especially when you go to hospitals or you are surrounded by people. You know, cough with your hand on your mouth, sneeze with emphasize that these washing, adding proper hand washing. There's no replacement for that. Nothing kills COVID virus. You can only wash your hands. You can only try to keep distance from other people, social distance, clean mouth, and that is all that can prevent a pandemic. And only if we have adequate resources at hand with adequate healthcare investment will we be able to handle a pandemic without. See, COVID was a special situation where you could not get into the community itself. But even otherwise, if we are ever faced with another pandemic, at least we should have healthcare resources sufficient in hand not to take away from the basic amenities like mother and child care, and other things, antenatal care, which are very basic things. So you cannot afford to have healthcare diverted from that side to deal with your pandemic or epidemic situation, which is what happened recently.
Thank you, ma'am. I think Lakhan sir has a question. So, Dr. Lakhan sir, over to you.
So your mic is
No, am I audible?
Yeah.
Thank you so much, ma'am, for an enlightening webinar and sharing your valuable knowledge today with us, ma'am. Ma'am, actually, I have two questions, not related to this hepatitis topic, but ma'am, something different, ma'am. Shall I ask, ma'am?
Yeah, sure, sure. If I know, I'll answer.
Ma'am, actually, ma'am, as you are a surgeon, ma'am, how does it
Yeah.
feel for you to work as a surgeon today, ma'am? Having achieved such inspiring heights in your career, ma'am. This is one my question, ma'am, to you.
So the second part of the question is the easiest to answer. So no, I have not reached any inspiring heights. So like Robert Frost said, miles to go before I sleep and miles to go before I sleep. Yet
Yeah.
yet I would not say even midway through my journey. And you get to see a lot of inspiring people around you. I get to see my seniors here, people who are much older than me, people who are working hard, striving at 75 years of age, and still wanting to do more work. So there is always an inspiration. So we need to look around us and see people who are never be there's a thin line being between being over ambitious and being what do you call wanting to not settling down, not become complacent, and having the zeal and enthusiasm to do more and do more. So so as a surgeon, when I operate on a patient, when I see the patient on the first day, the second day, the third day, and when I see the patient on discharge, or when the patient comes back to me after discharge, and you see the relief the patient has had, the pay time the patient came to you in pain or with whatever distress or whatever problems they had, and now they are fine. Or if you operate cancer patients and they may not have that much of distress, but you might have operated, you done a major surgery, and 2 years later the patient comes back to you, sometimes 5 years later the patient comes back to you alive, well, no evidence of any disease. I think that gives you so much satisfaction and happiness. No amount of money or no amount of I would say that nothing can give you the happiness that you see some human life walking with maybe a small contribution from your side. Ultimately, it's God who is above us, who's going to decide everything. We also are just, I would say, instruments in the hands of God. But still, that be able to make a small difference, a positive difference in somebody's life, gives you the required trust to go on and on. And yes, it's no, I haven't achieved anything in my life to say that I should be reaching anywhere, or lots to go. That is what I would say.
Absolutely, ma'am. Yes, ma'am. Ma'am, also my second question, ma'am. What are your views and what advice would you like to give to young medicals who aspire to pursue a career in surgery, ma'am?
So the first advice I give to anybody who, I mean, I have had people come and ask me about this. I have had a lot of girls come and ask me about this. So I say, choose a career, choose a choose a branch which entices you, where if you have to spend your entire day doing nothing but that, you'd still be happy at the end of the day. See, there are no shortcuts to success. Success is 1% inspiration, 99% perspiration. So you need to work hard if you got to succeed anytime, anywhere in life. So if you're going to be spending your 16 to 18 hours of a day doing a particular thing, it's much more important that you're happy doing that thing, and that should not become a burden to you. So a lot of people may take a particular branch because of peer pressure, or because that's the in thing, or maybe because they get a very good rank and that is the best option available at that rank. So I would say don't fall for those things because this is your entire life. You got to spend your life with this. So it's as important as your life partner. You cannot afford to compromise on your branch. If something makes you happy, when you're doing it, you will enjoy doing it and it will not be work. It will be like a hobby for you. You'll be pursuing it and you'll get satisfaction after doing it. Whereas if you enter into a field which is not your passion, then then that is hard work. Then the hard part of the work will be very hard for you. Whereas otherwise you'll just enjoy it and it'll be like a breeze. You will sail through anything. Every time there will be difficulties, you'll have difficult patients, you'll have difficult situations in each branch at any point in time. But for the most part, you will be happy. And if you're happy, that prevents burnout. That allows you to go to be persistent in the long run, because a lot of burnout is happening in our field, especially in surgical branches, because it's physically very tiring, to be standing throughout the day in the theater, then the whole night you are on the phone talking about what's happening to your patient, whether it's well, not well, and a lot of other issues. So your family life suffers. Your so you need to the other thing you need to be very clear is, you need to be very clear with transparent with your family about what your work is and what their expectations can be from you, because you are young. You're going to be a lot of you would be starting your families in another 5 to 10 years. You will have spouses who may or may not belong to the same field, leave alone the same branch. So you need to have some amount of clear talk between yourself so that the other person is on board about what to expect. Otherwise, like, I'm sitting here in my office right now, so my spouse should know that, yeah, I don't expect her to come home before 9:30, 10 o'clock, and they should be fine with it. And because that is also goes a very see, a supportive family also goes a very long way in preventing burnout and allowing you to aspire your goals and reach whatever heights you want to reach. You cannot be sailing in two boats trying to please your family on one hand, your patients and your work life on other hand. So that is how I see it, that follow your passions, whatever your passions are. No branch is easy, no branch is tough. If you enjoy it, it's easy. If you don't enjoy it, then any branch is tough to stick.
Definitely, ma'am. I hope, ma'am, your words might have enlightened all the listeners here, ma'am. Over to you, Faizan, Anushka.
Thank you so
Thank
much.
you, sir.
Thank you so much, ma'am. Your insights were truly inspirational. Now we are heading towards the end of the session, this great session. So now I would like to invite Dr. Riya Gupta to propose the vote.
Good evening to everyone present here. Good evening, ma'am. It is my immense pleasure to give vote of thanks. I would like to extend my gratitude to Dr. Ragini ma'am for showering us her wisdom and knowledge. I would like to thank our President, Dr. Lakan Prakash Gupta sir, and General Secretary, Dr. Amrita Shinde ma'am, for providing us this conducive environment.
Anushka, Faizan, you can over.
Thank you, ma'am, for taking time out of your busy schedule and inspiring us with your words of wisdom. Doctors like you truly are the backbone to our society. I'd like to thank everyone, all the participants, Dr. Ragini ma'am, Dr. Lakan sir, Dr. Amrita ma'am, and all the contestants and all the esteemed dignitaries on behalf of SNO India. I look forward to seeing you soon with another informative and engaging session. Till then, this is me, Fazan Yusuf, signing off for now. Thank you.
Thank you.
Thank you so much, ma'am. I think I'm done. Hello, Arya.
सर मैं बोलती जा रही थी
Okay, no issue, no issue. फैजान ने अच्छा कर दिया, संभाल लिया अच्छे से.